I'll tell you about our guest today. First of all, the topic today is intervention and treatment in the emergency department of substance use disorder type problems of vulnerable populations. Obviously, we've all been talking about that a lot here in New Hampshire and Dartmouth and across the CTN nodes. And the two speakers today are intimately involved in most all of the research going on in that area. They are the experts, and they are leading some of the primary studies that are going on right now within the CTN, as well as some of their own studies. So the speakers, first they're going to do a tag team. I think one's just going to go first and then second, but I'm not really sure. First speaker today is Dr. Ryan McCormack. Ryan is an assistant professor of emergency medicine at NYU School of Medicine. He graduated from Jefferson Medical College in 2000. He also earned an MS in clinical investigation, focusing on comparative effectiveness research, which is kind of key to the type of things he's doing now. He has a K-23 from NIAAA, focusing on efficacious pharmacotherapies. Again, having to do with treating folks in the emergency department, at least referring them from the emergency department. He's actually a practicing emergency medicine physician, has a broad clinical background in emergency care and addiction medicine. His research focuses on kind of what I said, collaboration and integration of substance use interventions in the emergency department. He's currently co-investigator for NIDA-R01 that compares interventions for opioid dependent patients. He's also been a key member of NIDA's CTN since 2009. He's currently lead investigator on CTN 079, which I assume we'll hear a little bit about today. But it's the ongoing project that we're involved with here at Dartmouth, which is co-led by the Northeast Road and our partners at Kathryn Medical Center and Regional Healthcare. And Ryan is also on the executive committee of the CTN for CTN. All right, that's Dr. McCormack. Dr. Hawk, she is an assistant professor of emergency medicine at Yale University. She works as an attending physician at Yale New Haven Hospital. She graduated from Drexel College of Medicine in 2010. Did a research fellowship at Yale, had the NIDA Career Development Award, maybe that was funded through the Career Development Award. She also got a Master of Health Science from Yale in 2016. Her research focuses on the same area, in particular overdose prevention in high-risk populations in the emergency department, and we're working on linking those folks to treatment, effective pharmacotherapy, and behavioral therapies. She's also on the executive committee for CTN 69. She's a co-investigator for Connecticut's Center for Disease Control Prescription Overdose grant. She's PI of an emergency medicine foundation project called Developing an Emergency Department-Based Intervention to Prevent Opioid Overdose, Listening to Patient Voices. And she's also been an investigator on CTN 79, that can be buprenorphine for opioid use disorder in urban rural settings. So, that's a mouthful, but you can see these folks know about emergency opioid use disorders and what to do with folks that show up there. They're going to help us learn more about that today. So welcome. Thank you.
Okay, good afternoon. I'm Ryan McCormack. And so we're going to talk about a number of things, and in general, it'll be introducing addiction care in the emergency department, or substance use care in the emergency department. I have no conflicts of interest. I'm funded by NIAAA, NIDA, the New York City Department of Health, NYU have internal funding, and I received study support through Alchemies, but the medication for my study of extended release naltrexone, medication is donated through the drug company, Alchemies. So, as this group likely knows, only a tenth of the patients, a tenth of persons with substance use problems receive treatment in a given year. And an SBIRT, or Screening, Brief Intervention, and Referral to Treatment, was one of the approaches that was launched to address this treatment gap. And the goal of it was essentially to identify and intervene patients at an earlier state of risky substance use or alcohol use in particular in general medical settings and leaving the more severe cases to addiction specialists. And the emergency department has been seen as an important venue for this. And part of that is that the emergency department is the front line of a lot of these substance use problems. Certainly patients that present with opioid overdose, and in those pivotal moments when somebody has an event that sparks their motivation for treatment. And that's often fleeting and can be a lost moment if not addressed at that time. And the emergency department, we know, has a high prevalence of substance use and is a risk factor for ED visits, is a risk factor for future overdose. And there are teachable moments that can be enhanced. And for many patients, it's the only source of care. But I mean, what is the reality? The reality is that almost no emergency departments screen and provide any form of intervention for substance use. And there are a lot of reasons why. And some of those are that the time and resources are more limited. There's a culture that the emergency department is to address chronic conditions, and that substance use can be better addressed outside of the emergency department where there are more plentiful resources. But yet, other chronic conditions like diabetes, if we identified a new diabetic in the emergency department, we would certainly refer patients, and that doesn't occur with substance use. There are other reasons, but those are the ones that I focus on. So a big part of my research interest is the priority has been to improve adoption and to take what is learned through research and clinical practices in certain areas where there's been success and translate it to something that's more feasible and acceptable and to support more widespread implementation. And important steps in this is really why Kate and I are here, to help as part of disseminating ideas through collaboration, bridging stakeholders. And so we have things that we can bring to you and we can also learn from you. And it's just, and it's important. And also then, so in addition to improving the quality of care, a lot of our goals are to change that culture that I was talking about and shifting perceptions. And Kate's going to talk a little bit more about those perceptions. So one specific focus of mine has been to streamline the processes of screening and intervention. So by screening, I mean detecting patients that have unhealthy, and I'm going to focus on drinking for this first part, unhealthy drinking. And that would range from risky drinking to having a severe alcohol use disorder. And in a previous CTN study, we looked at about 15,000 patients with chief complaints and tried to see if we could target screening with chief complaints, and it was a null study. And I'm going to focus on an area that has more promise, and that is abbreviating the screening and assessment process. So traditionally, it's been the audit or the alcohol use disorder identification test that was initially used for screening and assessing patients, and then that was an abbreviated version of the first three questions with the audit C to a single item screening question that's been validated to work so I differentiate unhealthy from okay drinking. But that will bring the number of patients with unhealthy drinking will be about 25% in the community, about 40% in the emergency department. But then you still need to do an assessment, and that kind of leaves you with the audit again, or there are some others as well. This is what the audit looks like. There are some things about it that I would discuss, but I want to focus on some other things. So here, what's in green is the people who screen negative. It's negative for unhealthy drinking, or they have, I don't like to say healthy drinking, but they have drinking that is not unhealthy. And that would be that they screen negative on the full audit or the audit C, or screen negative on the single item screening question. And anybody screening positive on single item screening question, I'm just going to abbreviate the CISC. Anybody screening positive on the CISC should get some form of intervention because they at least binge drink. And the question's on the next slide. And with the audit score, if you have above a 15, that differentiates people who should get a brief intervention and further assessment for possible alcohol use disorder and the potential need for referral or more intensive treatment. And so for me, an important differentiating point would be, can we among people who are CISC positive, can we identify who are kind of lower risk of the unhealthy and who are higher risk so that we can avoid having to do a lengthy assessment? And my research question, a little more detailed than this, but simplified is, can the CISC provide information on severity and risk stratification beyond simple screening? And the CISC is typically used dichotomously and the question is, how many times in the past 12 months have you had 5 or more drinks in a day if you're a male or in a female, or if you're over 6, if you're elderly, it's over 4 as well. And if you answer anything but never, that's positive. And so what I was looking at is the two bars here is if we, instead of using a dichotomous response, if we use a continuous or categorical response, and these are the categories used in some of the audit questions, and we piloted both, and the patients strongly preferred the categorical. They had an easier time with those answers, so that's what we used. And I direct a screening brief and an expert program along with an opioid overdose prevention program where we distribute naloxone. And in about 4,000 of those patients, we did the full audit after the single item screen, anybody who's screen positive on the single item screening question. And just some quick pictures that I'm going to run through. As here on the audit scores in the y-axis, and as you go across, as we hoped, on this jitter plot, as the frequency of heavy drinking days went up, so did the audit score, and there's none in the negative because we didn't do an audit score, or we didn't do an audit in somebody's screen negative. And this relationship held across age, sex, race, ethnicity. There's some images of some of those. All right, here is the big slide. So what we saw is, so in the top part of the chart, we have what we hypothesized was that weekly was going to be that differentiating point. That people who had a heavy drinking day of about once a week would be in that higher category. And that's actually what we found. So the sensitivity of weekly cutoff was at 89%. It was specificity of 74%. The area under the curve was 0.9. And across that, we did a k-fold cross-validation, which means you split the sample into 5 and then compare it to one another is a very good validation. So with that validation, it was an area under the curve of 0.85. And then below is if we, and this is what most people do in kind of similar research, is that if we imputed the people who were screened negative on the CISC, so we gave them a score of less than 15 on the audit, which we would expect. And with that, the sensitivity and specificity went up with an area under the curve of 0.98. And if you don't know much about area under the curve, that's like basically beyond exceptional. So this was really fantastic find for us. And so my conclusion is that if we can, this was I should say this was in a municipal or public hospital, so it's in this specific set, it's validated in this setting, but it is by asking that question and asking them to categorize it, if they have more than weekly, then that would correlate very strongly to having an audit score of greater than 15 or having moderate to severe, at least moderate severity. And so anybody who's screened negative, I would reinforce their behavior. Anybody who's screened positive I would say at least they at least have at least one binge drink a year, and I would educate them on that. And then people who screen positive, it will be dependent on what you have the capacity to do. It may be that you do a brief intervention, it may be that you assess, it may be that you initiate treatment. All right, I'm totally switching gears. Oh, not yet. So, so the other thing is, can this be done for drugs? And opioids are a big focus right now, and so there's a single item screening question for drugs, and one of the things is we could potentially target that to opioids and adapt the single item screening question to focus specifically on opioids. This isn't validated, but just from face validity, if you wanted to look at that, it would be a way of targeting to a population if you have fewer resources in particular. And the other benefit of looking at opioids is the efficacy of aspirin for drugs has not been demonstrated, but there is strong evidence of efficacy of medication treatment for opioids. So this slide I made in response to a conversation we had last night over dinner. So it's the Live Free or Die New Hampshire Libertarian license plate, and then another thing I found online is addiction is kind of a poster. Addiction is the only prison where locks are on the inside. And it's really just a matter of appreciating one another's perspectives and fostering change. And it's just, you can see things. The question I would have is if you want to liberty and preserving somebody's self-determination, does somebody with addiction really have their autonomy? Are they able to make choices that are authentic to what they want if they were not kind of in the grips of addiction? I'm not going to go too much into that. I would love to have that conversation, and I've written about it, and I'll give you that reference. So I like to start with just a quick clinical vignette. This is real name and Fred today. This is really what started my next project. So in January 2009, Fred was found on a New York City sidewalk, minimally responsive with presumed intoxication. He was soaked in urine and pronounced dead in the Bellevue Emergency Department of hypothermia. He actually arrived, anyway. By the time of his death, when he was at the age of 32, he had over 500 emergency department visits, 9 ICU visits, 8 stays, including 1 for hypothermia just the year before, and a dozen or so inpatient stays for detox and other medical concerns. And that's the Bellevue alone. And I've looked at, he had equally as many visits to other hospitals. We all knew him. He knew by first name. He was really beloved. And there was this outcry to do something. And somebody said, "Oh, Ryan, you're doing this alcohol stuff. You should have a memorial for him." And Dr. Goldfrank, my boss, said, "No, you should change care for people going forward." And so that's what sparked what I've done next. So it started with I started looking at administrative data, conducting chart reviews, followed by in-depth qualitative interviews, and I focused on the extreme end of the population. And what's in this, I looked at people who had dozens or hundreds of emergency department stays in a 2-year period with visits in each, and then looked at hundreds of charts, and I found that they are a unique population with through social dysfunction, cognitive impairment, psychiatric illness, physical and brain pathology. As we looked at their visits, but as their visits went up in each year, they had more costs and a linear relationship with their number of chronic conditions. What I then did is assembled a group of stakeholders across many institutions, and they were all targeting this group but working in silos. It included homeless services, the Department of Health, EMS, the hospital institutions, and I met with them, and they were eager to meet, and we came up with a kind of coordinated care that allowed us to provide services contemporaneous with their ED visits, and set up this alert system. And in the arrows, you can see, like, this is a pre-post there. ED visits and costs went way down. I also published with 2 control groups, and it was significant. And there was also our group, House. They've been homeless for an average of 14 years. It's just remarkable. And so then I applied for a K-23 and received it through NIAAA. And to give you an idea of their enthusiasm, they gave me a score of 10, which is the best you can get. And so they're really enthusiastic about this. And it was through a feasibility study where I added extended release naltrexone to this. And the aim was really to assess the feasibility and acceptability and to explore outcomes of initiating treatment with naltrexone plus fitness care management in patients with at least 10 or more visits in each of 2 years, and alcohol dependence. The first dose was given in the emergency department. I received 12 month supply for anybody who continued it in an outpatient or other setting. And we did research visits and compared it to getting a one-time warm referral. And we followed up at 3, 6, and 12 months. Just a quick glimpse at my construct, or my conceptual model. And we looked at healthcare utilization, drinking, quality of life, and consequences, and some potential mediators and modifiers. This data is, we have enrolled more patients since then, but we screened about 100 patients. Of those, enrolled 41, and then were able to randomize 34. There were some had some post-randomization failures to do medical screen fails. They were randomized. And I don't have time to really discuss how I consented them in the assessment of capacity, but there were a lot of ethical measures to make sure that we maintained research ethics. And some amazing results. So this is the 3, 6, and 12 months for the intervention arm and the standard care arm. And green means they completed their research visit. 0 means that they're out of their window. Purple means they're not in the window. And here's their window. And they had almost 3/4 of all of the possible research visits where we've been able to track them down and complete them. None of them have phones. None of them have homes. And here is the receipt of the injection. So this is per patient across the top. Again, the same thing is made. And so you can see that of the possible shots, 2/3 have been given almost, and some received all of them. Those patients did. I'm not going into the outcomes, but there are some good ones. Just talking really more about feasibility here. So adverse events, there's one person that we excluded. We're still following him. He had a traumatic brain injury and had a very complicated alcohol withdrawal. I call that possibly related because I helped him get admitted to the hospital for alcohol withdrawal, where he then had probably an anoxic brain injury. There were other ones were not related. So the other thing that's great is that I did not apply for an R01. I applied for a K to do a feasibility study, and I had this beautiful system set up. And then Hurricane Sandy hit, and then the Great Recession hit, and the care management went away, social work went away. We had an alert system that is how I identified and tracked patients. That went away. Our ability to use a share drive, which is how I communicated with the staff and the social workers, that no longer exists. That went away. And part of why my enrollment stopped is that I had my staff had a number of problems, and then there was a turnover in homeless services, EMS. Every connection I had dissolved. And so this is with, these results are in spite of some truly difficult situations. All right, I'm just about to hand over to Kate, but there was remarkably high recruitment, adherence, and retention rates. The results are quite good. But what I will say is, although it looks feasible and acceptable, it's not in a state that is ready for that. And so when I talk about adoption, if I were to promote this, and I could, I had the data where I could write it up and say, oh, look, it's feasible and acceptable. Give me an R01 and you should do this everywhere. It would be such a mistake because the problems that existed really showed me what needs to be done. And I am trained in emergency medicine, internal medicine, addiction medicine, and have an aerobat in my office and was able to do a lot of things that are not realistic. So there are some things so I've learned what is necessary, but it's not, and I can make an argument that's feasible, and I do think there are ways to make this feasible, and I do think there's a role for it, and I can give you a much more compelling argument of why we should be addressing this patient population, but in the period of time I have and I've already exceeded, I need to stop. And I have some publications that I can tell you about. The first one are qualitative interviews with patients with this, and it's what I'm most proud of in my life. And this one is like how we consented patients. This one is the initial pilot study. We've already basically heard about it. And this one is about civil commitment and liberties and all that stuff. So I'm going to hand over to Kate. I also do opioid work, but so does Kate, so I'm going to leave that to her.
Thanks, Brian. Thanks, Brian. I'm really glad to be here today. So you already heard my link meeting questions, so you don't need that. I have some research funding inside in EMS, but no other disclosures at this time. Clearly, you all are well aware of the opioid epidemic. I like to use the slides to state data, but I like to use the slides because it really shows the increase in opioid-related ED visits. Especially increased 100% between 2005 and 2014. Green is ED visits, and blue is inpatient stays. And I like this slide because I think it shows, depending on your perspective, these are people that are in contact with the healthcare system and have the opportunity to be screened, identified, and linked to treatment. And obviously, we know that is one of the challenges. 1 in 10 for all substance use disorders, only about 1 in 5 for patients with opioid use disorder. And there are many, many, many barriers as to why people do not receive treatment. I'm sure we could come up with a list. We could fill this board. One of the ones that I wanted to take the opportunity to focus on, particularly from the emergency department, which is Ryan alluded to earlier, is really this concept of stigma. And I think it's important both from a patient perspective and from a provider perspective. So as I was trying to inform myself more about what stigma is and what it actually means and how we can think about training the way that we think about ourselves, I came across this model by Lincoln Phelan. And essentially, they define stigma as a social process entirely dependent on social, economic, and political equilibrium that leads to status loss and discrimination against stigmatized. And these are kind of 4 different concepts, and I like this because I think this is something that we see. How many people work in the emergency department? I know there's at least a couple. So this is something that we see certainly every day in the emergency department across healthcare settings. To be fair, but I feel like perhaps more so in the emergency department. This came up in a discussion earlier, in part because emergency physicians and emergency staff, we see people when they are generally not doing well with their addiction. So trained in internal medicine and family medicine. They have the benefit, and addiction medicine have the benefit of seeing patients who are doing really well with their addiction. And in general, if we see them in the emergency department, we don't even know it because they're doing so well with their addiction. And so these are kind of more of the things that at least we see in the emergency department. So what's different about addiction? And this is obviously not limited to the emergency department, but there is this perception of choice. And have a lack of understanding of the biological basis for addiction. This is both on, or not both, it is on the part of patients, on the part of communities, on the part of families, policymakers, but also very much so amongst healthcare professionals. We know that there's a dearth of addiction medicine training in our medical schools and in our graduate medical education curriculum. And, the idea that while there may have been some choice somewhere along the line, but by the time that you actually develop a kind of moderate or severe opioid use disorder, the rewiring has occurred. This is, it's not, by and large about getting high anymore. It's really about trying to avoid profound withdrawal and misery. There's also some kind of confusing, inaccurate terminology that I think is challenging both for lay people and them in healthcare settings. Some of this is improved with the change from DSM-4 to DSM-5, but especially with opioids, when you have kind of prescribed and not prescribed, and you're taking it, maybe one more prescribed a day. Kind of what does that mean, and how does that fall into opioid use? And I think that the new DSM-5 terminology is better, although it's still not really widely adapted or used in healthcare settings or kind of by the media. Not all use is a disease, and not all substance use disorders are unsafe. She speaks to acts as a continuum, and so while there's, we can say someone has diabetes or someone has hypertension. Well, those are, also can be continuums of disease. I think that we like to say, this is, one disease, and I think a lot of addiction is really, it's a continuum. And then the last thing that I want to really focus on is kind of the role of language. And I think this is so important. And I'm speaking to this kind of as a healthcare provider. Just because the words that we use to talk to patients and the words that patients use to kind of identify themselves, I think it really shapes the opportunity to form kind of a therapeutic alliance and an opportunity to really help change establish a relationship where you can help change the trajectory of a person's substance use. So these are articles that I'm sure many of you have seen or are familiar with. Kelly and Wigman and Rich Bates have done a lot of work around kind of the language of addiction and really changing the language and like about Kelly. And so I highlight this because there has been a very conscious effort on behalf of addiction medicine leaders and certainly NIDA and people who spend a lot of time day in and day out thinking about addiction, how important it is to not use words like clean and dirty and not use words like addict, and to really try to move to more patient-centered language. These sort of changes take time, and I think that there's still a lot of work to be done both in the healthcare setting and then also with the media. I mean, I'm assuming there's a lot of folks here who interact with the media who have opportunities to think about how we use these words. And so this is from a couple of different sources, but and shouldn't necessarily be a surprise to many people here. But the idea of kind of avoiding addict, abuser, dependence versus opioid use disorder, the clean and dirty. Substitution is a big one. I think even in the medical community, there's a very pronounced perception that MAT is, sometimes perceived as substitution. There's just a lot of opportunity for education around the fact that addiction is really about behavior and it's not necessarily about your mood receptor. And then some other things around misuse and dependence, just because it can be confusing. So to kind of bring us back to our talk here today, so if we're looking to identify patients with opioid use disorder, which is most of what I'm going to focus on today, why would you use the emergency department? And really, I mean, this is where the patients are. We may be the only place that people access the healthcare system, certainly high-risk patients, and we have the opportunity to interact with them at a time when they may have had some sort of precipitating, event that allows them to think about their substance use in a different context. So we see people after overdose. Sometimes people come in seeking treatment. Even I'm fortunate enough to practice in New Haven, where we have a fairly robust treatment community. There are people can walk in off the street into certain places and usually get connected to treatment. We still have a lot of people who come to the emergency department for it. And then we see people who are identified through screening, which Ryan alluded to. And this isn't just me. This is most people who think about addiction. Really, the idea of reducing morbidity and mortality is really it's not a single-pronged approach. I mean, you really have to think about prevention, around access to treatment, and harm reduction strategies. And there's certainly a clear role for all of these in the emergency department. I'm going to spend most of my time talking about access to treatment and harm reduction because I think the role for prevention, particularly around prescribing for adolescents and opioid needs populations, has been pretty well appreciated. But what I'd like to talk about is the study that was done in our emergency department. My research mentor is Gail D'Onofrio, who I'm sure many of you know are familiar with her work. And so this is a study that was done enrolled between April 2009 and June 2013. They were adult opioid dependent because this is DSM-4 patients that had an urine toxicology positive for opioids. And patients were enrolled, 9% were enrolled after an overdose, a third came and seek treatment, and the rest were identified by screening. And essentially, so these were ED patients who are willing to enter a treatment trial, which is an important point, and they were not all overdose patients, which are the other thing that I just want to highlight, because sometimes the story gets, or this study gets misapplied or misinterpreted. And so these three groups were randomized to a referral, a brief intervention, and a facilitated referral, or a brief intervention with buprenorphine, ED-initiated buprenorphine, and follow-up with a primary care doctor within 72 hours. for continuation of buprenorphine. And so our primary outcome was treatment engagement at 30 days. And as you can see, the patients that had either ED induction or unobserved induction prescribed from the emergency department were more than twice as likely to be engaged in treatment at 30 days, which from an emergency perspective, that is, I think, all we can hope for. And as you see, I mean, these numbers are not terrible either. So people did find their way, into treatment. 30, I think it's 37 and 42%, so the other two arms. But I mean, there's clearly an overwhelming benefit to actually giving people medication. This is one of our secondary outcomes with self-reported past 7-day opioid use. It also decreased more significantly with buprenorphine. The other thing I want to highlight, which again is not necessarily going to be a surprise to many people in this room or who are at this talk, this didn't go to zero. I mean, that's not. I don't think that's the right bar for moderate or severe opioid use disorder. Certainly not within the first month or so. That's certainly an ongoing goal. But the idea is really we want to reduce patients' risk of having a bad outcome or morbidity and mortality associated with opioid use, and particularly in the era of fentanyl. I think every day you can decrease someone's potential exposure to fentanyl is a win for everybody. So this is, I mean, it's not a case in the sense that there's a lot of details, but we know that in many emergency departments around the country, and certainly at one point, where I trained, someone would come in after an opioid overdose, and the question is kind of what is the role of the emergency department in providing care for this patient? And so we know that in a lot of patients, in a lot of places, they certainly get life-saving interventions. You get naloxone, you get oxygen, you get your vital signs monitored, you get the mental status and stuff. But kind of what are the other things that we could be offering or could do from the emergency department? And so I like to put this up there because I think these are other examples of acute emergencies, and these are the life-threatening emergencies that you think of in the emergency department, where you would have a page overhead. This is a resuscitation that's happening. These are time-critical things, and we think about stroke, we think about STEMI. But it's really interesting because we're talking to many. We realize that overdose means that somebody has stopped breathing. But the link and the switch in the brain from this is end stage of opioid use disorder, just like stroke and STEMI is I think that changing the model of how we think about overdose and opioid response and opioid use and ED is a little bit more structured response. So these are things that we do in our emergency department. There's certainly, I would love to tell you, everybody gets every option, every hour, every day. It is not the case. But we do certainly strive to offer a variety of options to patients. And this is not just after overdose, but in general. So we have brief intervention referral to treatment. There's overdose prevention and naloxone distribution, and then ED-initiated buprenorphine referral for follow-up. So Project Assert is a model we have had since 1999. It's based on the Boston Medical Center model, started by Ed Bernstein. It's fabulous. It's health promotion advocates in the emergency department, and basically these are they are professionals who know all the treatment resources in our community. They are trained in brief intervention. They don't necessarily have to have masters or nursing level training. I mean, the idea is that we train people how to do brief intervention and to interact with people, and that's really the most valuable part for these folks. And they collaborate and educate. They do a lot of work with our residents and our faculty around trying to keep people honest about what we can offer people. And in the last in 2016, they referred more than 200 patients to counseling education referrals. And this is not just for opioids. This has been, started out really kind of more focused on alcohol, but it's really all also the emergency department. So they're great. The other thing that we have started doing since August 2016 is taking naloxone distribution. We were fortunate enough to get some from our Department of Public Health. And so we put them in people's hands on their way out of the emergency department, along with some overdose prevention education, how to identify an overdose. Absolutely, you must call 911. And one of the things that I really like about this program is I think that, even if you have somebody who, as you approach them, if your first and only thing that you ask them is, do you want treatment? you hear no more than if you have, or at least in my personal experience, have had more benefit in actually getting people to accept treatment, or to really building that therapeutic relationship I was talking about before, where people, if you say these are the things that we're able to offer you, and we really want to be a partner trying to help you be as healthy as you can with your opioid use disorder, people have more faith in you. So I think this is a population that has generally had a lot of not great experiences in the emergency department. So I think it's helpful both for the overdose prevention and education, getting naloxone, and it's also helpful for the relationship. Although I have no data to support that. And so really our goal here is, I can just go through this quickly, is, so we have the emergent care, you save a life, and really the idea is to, not just save the life once with naloxone, but really to initiate treatment to, link to treatment, to give them naloxone. The idea is to really change help the patient, because we're not changing it, we're helping the patient change the trajectory of their disease. And so I think that's really cool thing that we have the opportunity to do. I just want to take just a couple of minutes about, I don't know what time it is. Okay, perfect. Okay, so just a couple more minutes. So this is just a couple of nuts and bolts about kind of how we do ED to buprenorphine. So this is a 72-hour role. I'd assume most people are aware of kind of the regulations around buprenorphine. You're required by law, you're required to have an X waiver to prescribe it, which is just an 8-hour training. Was initially only available to physicians and is now available to PAs, APRNs. But this rule here is a 72-hour rule, which basically allows any provider to administer a dose of buprenorphine or methadone in the emergency department or in hospital for up to 3 consecutive days while linking people to treatment. So this is something that is available to people to do for patients who are having active opioid withdrawal and who don't have X waivers or other ways to link people to treatment. This is the clinical opioid withdrawal scale, which is what we use to decide whether or not kind of what the risk is of precipitating withdrawal with buprenorphine. As buprenorphine is a partial agonist, if you give it to someone who has other opioids on their mu receptor, you will displace them and can precipitate withdrawal, which is a pretty unpleasant experience for everyone involved. And so there's a lot of focus on trying to avoid that experience for patients and providers alike. And so we use a moderate or moderately severe withdrawal for ED induction. And then if someone doesn't meet that criteria, then we can send them home with a prescription for 2 or 3 days of buprenorphine for unobserved reduction, and then they follow up with their provider. This is the kind of nuts and bolts of the form that we use for our program. So we, as I mentioned, we have 5 places in New Haven that have agreed to take patients from the emergency department. And part of this list kind of was formed, and Gail is the one who made these relationships happen, and it was in the context of a particularly bad rash of overdoses. And I think that our community partners, they understand and want to help us transition care. And so the things that we do, so there's a kind of a base brief history. We do a urine drug screen because we do want to make sure that patients actually have opioids in their system. This is a little bit of a challenge with fentanyl because a lot of the urologists don't actually test for fentanyl, and particularly in New Hampshire, we understand there's a lot of fentanyl only. So that's a challenge. That's all I can really say about that. And we do liver function tests. We do a mini skid because we certainly want to make sure people at least meet criteria for moderate or severe opioid use disorder or initiating buprenorphine. We see plenty of overdoses that are people who have tried heroin for the first time or use it, twice a year, and those are not people we want to start on buprenorphine, so we want to make sure we know our patient population. And then we have to score the dose given and then fax this form to the provider or send them a note through our electronic medical record. This is information about Data 2000 training. SAMHSA is actually offering free training. They used to be $200 to like that get trained, and there's a lot of interest and goals in trying to increase access, and so increasing the number of waiver providers in our community, I certainly understand that's one of the challenges that New Hampshire is places where we can send people. And then the last thing is that I just want to highlight is it's really sort of a question mark. There's the FDA has recently approved one formulation which won't really work in the emergency department because it requires a 1 week sublingual lead-in, but they're anticipated to approve in the next couple of weeks an extended release buprenorphine that won't require that lead-in. It's a subcutaneous injection, one lasting 7 days and one 30. And the question is if there's a role for using that in the emergency department to link patients to treatment as opposed to sublingual, and it has some potential benefits around it avoids concern about diversion and things like that, which many people are concerned about. And there's some questions around whether or not this will be able to be given under the 72-hour rule, even though it lasts more than 72 hours. You're only giving it once. The question is whether emergency departments will be able to build programs around, a protocol for this, as opposed to requiring every physician to get an X waiver and every physician to do that. That is certainly a barrier that we've identified in emergency departments. And I think I'm going to stop there. I'm sure there are questions concerning any of those things, but we're happy to be here and happy to see that people are interested in this. I mean, obviously, it's neither. You guys are very interested, but yeah.
You also see if anybody from the remote side.
If anybody online has a question, please feel free to ask it, but just please know you are muted, so just unmute yourself before you begin talking.
Great question. Great talk, and I love the emergency room idea. I was just curious about the 72-hour rule. So someone comes in, it's within the time frame that they're in the ED, there's clear signs of withdrawal, they're given you generally just one tablet, sent home, and then with the expectation they come back 2 more times. Now, the ones who do that versus the ones who, I guess they're stabilized but sent home with a couple of doses, anecdotally, do you feel like that changes the likelihood of following up with the provider for longer-term care, or maybe has no effect? Or?
So, I certainly don't have data to answer that question. This is something that I had done, but while I was waiting for my X-waiver to come through, and there's something, from a very selfish standpoint and an educational standpoint for my residents, there's something just truly amazing about, somebody who was really kind of reticent the first day on Saturday when you saw them, who came back on Sunday and walks up to you, shakes your hand and says, "I have not felt this good in my whole life."
Yeah.
And, to be able to show that to residents, drag residents from all over the ED. Come meet this guy. But there's clear barrier. These are, multiple ED visits, multiple co-pays. Having to wait hours in the ED. You can't. There's no way to get around it. It's a controlled substance. So there are kind of big patient barriers for that. I don't know that I would actually anticipate that it changes the likelihood of them following up in treatment. But we've had pretty good success with people following up.
I'm curious for patients presenting with overdose versus Narcan.
So you and everyone else in the country. The answer is not safely, to my knowledge, right off the bat. So naloxone certainly precipitates withdrawal, but it wears off after 20 to 45 minutes. And my opinion, and I think of a lot of, from talking to other people, their opinion is that, the idea of kind of doing buprenorphine on top of naloxone is unlikely to yield good results as far as, because we don't necessarily, you're not fully in withdrawal because we don't give large doses of naloxone. So the thing that I do, and this is kind of, I would say the bulk of my inductions are actually unobserved inductions, and it is for patients after opioid overdose. And essentially, people get naloxone, kind of wears off. You have a conversation in the emergency department, you send a urine, you send the detox, and if they're interested in treatment, the naloxone has worn off, so they're able to have a conversation with you. They're not explored withdrawal anymore, but they're not in moderate withdrawal. And so I usually do home induction. And that has worked well for us. There are a lot of providers who, have big concerns, or are not comfortable doing that. And, I understand, concerns about diversion and things like that. But, I think buprenorphine is treating opioid withdrawal, and they get treatment. Not every one of them, but I think, certainly enough. And it's worth it.
Thank you for the commercial presentation. This is such important work that you're doing, and it's so needed, and it's such a beautiful example of how we can creatively think about different points of access to effective, science-based treatment outside of and, supplemental to our traditional model of care. I have two questions. The first one is for Ryan. You gave us that teaser about this great data that you didn't tell us. So I'm wondering if you could say a little bit more about your outcomes from the alcohol study. And the second question is, I think given that folks in this room and also a lot of the folks joining remotely are from New Hampshire and surrounding states, it would be great if you could speak a little bit more about the collaborative project that we're launching now in New Hampshire in collaboration with Bellevue and the Yale colleagues, just so folks know a little bit more about what's about to happen in our community. Thanks.
Sure. So there are a few different outcomes. One is healthcare utilization, and one of the primary reason why one of the reasons why I chose that as the primary outcome is I didn't expect to be able to follow up with the patients as well as I have been able to. Plus, this patient population is so severe they don't remember the day before, let alone, when I submitted the grant, NAAA asked me to do a 90-day timeline follow back, and this patient population really doesn't remember the day before. And so a reliable outcome would be healthcare utilization. And the reason why I didn't do that is that New York is densely populated with multiple hospitals, and I don't want to just show the Bellevue data because some of the people who were placed in housing out of our catchment zone. And so the group that received the intervention was more likely to be housed. And some of that housing was out of our catchment zone. So they may be going to Harlem Hospital now because their housing is in Harlem instead of Bellevue. And I don't currently, there's a delay on the access to statewide data. So I can't give that. As far as drinking, I can tell you, what I would say is that this does not work for everybody. There seems to be a group of people for whom it works very well, where people will come up to me and say, Doc, I don't know, this is a life-saving medication. This changed my life. And so for about 4 of the people, they just stopped drinking and had a profound response. And a couple of others, they were able to get, what we saw is that they would go from drinking a half a gallon a day to a pint, and they became a little bit more clear. And then instead of being admitted to detox or to the hospital and then leaving against medical advice after a day because of their withdrawal or for whatever reason, they complied with it. They adhered to that. And I think 3 or 4 people ended up going to physical rehab because a lot of them have physical ailments as well, and ended up in not quite nursing homes, but facilities where and that also obscures their drinking because they're less I don't know if it's anyway, but what I would say is that there's a huge number of people that a big proportion that decrease their drinking. There's a subset of those that receive naltrexone that seems to have no effect on them. But there are some that just, the stories are also interesting. I saw this one guy who came in and said, I saw him just incredibly intoxicated, and he's like that medicine is I don't feel like drinking, and I'm like, name, you're wasted, and we have I know them, so I can we use the language, and he's like, yeah, but I didn't feel like drinking. And I was like, well, what? He's like, what did you drink? He's like, well, I bought a fifth, and I was like, well, what if tomorrow? He's like, I didn't even feel like drinking. I was like, well, what if tomorrow you buy a pint? He's like, Doc, I didn't even think about that. That's the greatest idea. And so, like the next day, my RA was walking in from the subway and saw him. He sleeps on the street, saw him, and he followed her in, and he was telling me how he woke up, he didn't feel like drinking. He's like, I walked by a liquor store. He's like, I even looked in the liquor store. He's like, and I was thirsty and I didn't know what to do. So I went to a bodega, which is a small store, convenience store, and he's like, I went in to get a thing of orange juice, but there was a beer next to it. So I got a pounder and like just came in and I would say he was our highest user in the hospital. And, like the best data is following each, like a case series. That it's so much better than giving, like all of the data is flawed. And so if I went through and each one in some way, and I'm really struggling to figure out how to do this. And so that guy, he was sober for a while. He got into housing. He got lice and bed bugs in the housing. He left the housing, had this kind of crazy situation, lapsed for a bit, got back in, was doing well for like 3 months, and then his daughter died. And then he had this kind of a bad outcome for a while, and then was doing well again, and was sober for a year. Got permanent housing, which doesn't exist in New York anymore. I mean, it really is. And then like a month ago, he has so many medical problems. He died of a heart attack in a bed in his own place, and it was just like the nicest death. And he actually came to the emergency department like a few days earlier, and I couldn't get him into treatment because he wanted to occasionally have a beer, and he wouldn't drink a whole. One of the things he told me is like, my family's having a barbecue for 4th of July. He was like, I'm not going to lie to you, I want to have a beer. And our substance use treatment program wouldn't allow him to come in because he wouldn't subscribe to abstinence, and so he couldn't get into that kind of treatment. And so, that gives you an example of how naltrexone worked for him. And there are about 4 people that had that response that had that profound of a response. And that's not including people who are in like facilities. And then as far as our study, so what we are, part of why I put up the adoption slide, and so we have this model from Yale that is remarkable. And in that study, there are some things set up, like David Filene can take the patients, and there's a structure, and that's the way you do studies in the first, like, to demonstrate that it works. And then we want to take this and other clinical experience and make it more generalizable, and learn about places that aren't Yale, that aren't big academic centers that have potential resources, and learn about places that have different levels or different resources. Like here, there's a lot of locum tenens. So if you have a doctor who's a temporary doctor for a while, as opposed to a staff doctor who can get waivered and be your prescriber, locum tenens is an agency where you are a doctor at a spot for maybe a few months, or where there are no resources in the community. Or at Bellevue, where I am, there's one nurse for every 20 patients, and there's no transport, there's no EKG tech, there's no phlebotomy, it's totally stretched resources. And so how do you translate interventions that have the potential to work into different environments? So we're here to learn about these environments so that we can learn about the experience at Yale, and you can learn about the experience at Yale, we can learn from what's here, and we can come up with solutions to this. And so the study that we're doing through CTN 79 is we are working with people at, right now it looks like Valley Regional Hospital and Catholic Medical Center to help implement clinical protocols for induction of buprenorphine in the emergency department with facilitated aftercare, and helping them to identify people in the community and all the steps necessary to make that happen. And that will be rolled out as a clinical protocol, not as a research protocol. And then just like you would a quality improvement project, the data that are collected through that process can be used to see where the process has succeeded where it may not have. And then we'll also enroll patients in mixed methods interviews, so qualitative interviews with some quantitative assessments. We'll be interviewing providers and other staff and community stakeholders to learn about the barriers and facilitators to implementation, to kind of iteratively inform this program, this protocol. And then we'll also be enrolling patients in interviews and assessments after they've gone through the emergency department to see what their experience was in the emergency department, learn about their experience has been, their barriers, facilitators, but also we'll ask them about their experience after 30 days and their outcomes so that we can learn about whether they have connected to aftercare and and their impact on their use.